Hello everyone, I'm Dr. Darsh Shah.
And I'm Dr. Altamash Raja.
And welcome to Medicine Redefined,
a podcast where we will explore the often overlooked but necessary components of health, what we consider to be the fundamentals.
We will investigate topics and practices that can give you and your patients the best chance to optimize a healthy lifestyle. It's time to move the needle forward and put the health back in healthcare. Our guest today is Dr. Nikhil Verma, who, like myself and Altamash, is PM&R trained, and he is a practicing physician within the realm of sports and spine. He's currently located in Ohio. So the reason we brought on Dr. Nikhil Verma is because he is active on social media. And like myself and Altamash, we're all trying to filter out the noise. We're trying to extract the good information, the good voices on social media, while trying to navigate that complex world that we now live in with so much misinformation. Dr. Verma also has a YouTube channel where he talks about the things that we don't learn in med school. Yes, there's a lot that we don't learn that we truly need to understand whenever you become an attending and you start to see patients in the quote unquote real world. So throughout this episode, we're going to be talking about the things we didn't learn in med school. We're going to be talking about how to filter the noise from the signal on social media. And we're also going to talk about what the scope of a physician is and how do we truly approach patients. And so throughout this episode, you're going to hear all three of our opinions and kind of our mental models. So without further ado, enjoy this episode.
All right, Nikhil, welcome to the show, man.
Thanks. I appreciate you guys having me on.
Yeah, I've been excited for this conversation for quite some time, particularly because, I think, well, I guess now we officially met down in Baltimore, although we don't really get to chat much, but I've been following you on social media for quite some time. Thanks to Darsh, she introduced me to you, and I really love because you have some strong takes on social media. So I'm really interested in getting some of those here. Hopefully things will get a little bit spicy, and hopefully nobody will get in trouble today. That's not going to be the purpose. But before we kind of get into that and get your take on a variety of different topics, I want to talk a little bit about your background. I know you did some training over on the East Coast, right? You did residency in New York. Is that right?
Yeah, that's right. Brooklyn, New York, yeah. Kingsbrook Jewish Medical Center. Yeah, did my
Kingsbrook, man. Yeah,
there.
I remember. Yeah. Where did you grow up?
I'm from north of Columbus, Ohio, Marion, Ohio, small town. Then I went to Ohio State for undergrad, so kind of wanted to come back here for a long time. Finally made my way back.
Where was med school?
St. George University. So
okay.
I was on the
Gotcha.
Global Scholars Program, which is pretty cool. For the first year, I was over in Newcastle, England. And then the second year, we went down to Grenada. And then my clinical rotations were in Brooklyn. And that's kind of how I got looped into the Kingsbrook system. So
awesome.
It was a good time.
So you've kind of got a taste of a variety of areas, variety of environments, variety of patient populations, I'm sure. And you ended up back in Central Ohio. That's where your practice is, right?
Yeah. So I have two offices, one in Columbus and then one in my hometown, Marion.
Awesome.
To add to that point, I think that's like a good starting off point in itself because, so I saw all these hospital systems from, not just medical school, but then in residency, we rotated through, or in med school, we rotated a bunch of hospitals. Then intern year, I even went to Rochester Hills, Michigan, and I was exposed to 3 or 4 different hospital systems there and different practice types and all that stuff. And then I went to residency where we were rotating at different hospitals, especially 3rd and 4th year. Mm-hmm. So quite the background of experience that I feel like I have.
Did you always know you wanted to go into something musculoskeletal, sports, spine related?
Yeah, I think a lot of people that that are drawn to the physical medicine and rehabilitation world, we are either have an injury of our past or something along those lines. So I actually had a pars defect that took me out of playing football when I was in high school, and it really led me into like a deep-rooted depression and back pain, as we know, so common and interlinked and all that stuff. I started really getting into working out and lifting and strengthening and stretching and all this mindfulness and all that stuff. So, I kind of figured, I'll go to med school, go to sports medicine. I love sports, as most of us do. And what happened, I was doing my sports medicine rotation electives in my 3rd year / 4th year at Kingsbrook, and I was going to the clinics. I'm like, well, man, this is just this is just physical medicine rehabilitation clinic with 4 sideline coverage. And not that there's nothing wrong with sideline coverage, especially if you want to do that, but I would rather be watching the game, having a drink with a friend, than sitting and feeling like I'm working. And also, I didn't particularly care to watch, JV high school boys volleyball. Not really my cup of tea. So I was like, okay. So I was actually lost for words at that point. I'm like, what do I do? I was talking to my, at that time, we were PGY 3 years, and he was like, hey, I'm going to do this interventional spine and musculoskeletal health NAS fellowship. You should apply too, because it seems like that's what you want to do. The more I read into it, I'm like, wow, that's awesome, because it's all the procedural stuff, but I could still do musculoskeletal stuff, which is where my real passion is. And thanks to Frayne for recommending it to me, and never really looked back.
Yeah. I don't. The poor JV athletes that might even be listening right now, just so butthurt at this point.
They're in better hands than I could treat them. So,
so having this diverse background and just so in Brooklyn, I mean, you've seen patients from all walks of life, and Central Ohio, drastically different population. Down in medical school during your rotations, again, you're kind of stationed in all different places, as you mentioned. So you have a sense, and I've heard you talk about this, just kind of the system of medicine, the business of medicine, all kinds of things. I guess if you could go back and think about it when you were first going into the field, maybe before starting medical school, I mean, you must have shadowed some folks. You must have had some exposure into that.
Yeah. Definitely.
And you've been practicing for how long now?
I opened my practice at the beginning of 2020, so going into
a couple of years, right, under your belt. So how would you say the medicine of today is different than what you expected as you were entering or matriculating for medical school?
So I think that's a great question, because, we get indoctrinated into hospital systems and how the hospital system works. And then you have this shiny star object of a university hospital. It's above and beyond everything else, and has all the credentials, you have all the books, you have all the authors, all the people putting out these good research papers, which is fantastic if that's exactly what you want to do. But I could go have a conversation with one of these individuals. Heck, we can even talk about my own fellowship director who's in private practice. I ran into him in New York, thankfully, and we got a great chance to catch up. And he's like, what he doesn't know about the back end stuff just blows my mind. And it's medicine is not run efficiently. We're not getting the care to the people that need the care the most. We're not getting the education to them. We're not getting the resources and all that stuff. Darsh has like such a great positive outlook on life with all these things, and I used to see myself in that, but I've been like so jaded. Because I know when I walked into Brooklyn Hospital that this person who just got his leg amputated, they're not going to listen to me if I want them to change their diet and go smoke free and stop eating this and get on their blood pressure medications. I know full fact that they're going to be back in the rehab hospital in 6 months. And because they amputee now they don't have the access to get around and exercise. And I'm not sitting here going to blame the patient, which we don't force ourselves. These social media influencers, not you guys, but you know who I'm talking about. These people who don't know anything about medicine or how healthcare works, and they're like, "Oh, it's easy to go take care of yourself. Just go walk." And these people don't have access to good food. That $1 cheeseburger is what they have to split between their family. So that's like what my realistic view of the world is, and I still believe that we can all be our own advocates and fight for ourselves.
So I certainly agree with you that Darsh has an incredibly positive attitude. In fact, that's one of the reasons I wanted to link up with him, because I was like, I'm going to steal some of that energy. And so far I've been unsuccessful. He's holding it to himself. But that's an interesting point you bring up. We had a previous guest come on, and one of the things we always like to ask people towards the end is, how do we add the health back to healthcare, right? That's kind of loosely the mission of the show. And this person responded by is like, we don't. We have to kind of destroy it and just create a new one. I see that point, but at the same time, I do think that the next generation of doctor is a little bit different, right? We have different tools, we have different mediums of communication, patients are more informed. I mean, we've got the internet, right? And so our approach has to be like the way we were learning, the way we were communicating with patients, the way we were practicing 20 years ago. It doesn't work now, and it's not going to work 10 years from now because how rapidly everything is evolving. And so, I still like to think that there is something that we can impart, and we're still part of that new generation, right? Because we're all fresh. Like I'm a brand new attending, you're still a couple of years out. So what is it that you wish that you would have learned where maybe you wouldn't have been as jaded, so to speak?
Yeah, I guess jaded is has a lot more.
It's a hard term. I know you don't mean that literally, right?
Yeah.
But I see what you're saying. Yeah.
I just see it in a different perspective, and I am with you guys. Like I want to make this a positive place, and I do spend the time, and that's part of the reason I went into private practice. Is I will sit here and talk to my patient for 45 minutes. Like, yes, I'm looking at the clock, knowing that there's a patient in the next room waiting for me. I know I have procedures going on, but if that's what it takes, especially with these chronic pain patients, which is so poorly understood, even in the medical society, even in the pain society, that I know what it takes to get them to listen. Will they go the one way? I don't know. But I think we have some advantages to us that we have enough people like us who are positive about this, and if we can keep our head of steam, we can find the right ways. I think one of the wins was getting a health coach, being paid for by insurances. Now, I feel like, it should be limited to doctors and stuff like that, but it's finding centers of excellence. I use that term loosely of, all right, how do we get a family medicine doctor all the way up to orthopedic, neurosurgeon, getting all the specialties working well within a network. And this is something that's been proposed. They're called accountable care organizations. Doctors, hospitals, other care providers. They financially benefit their patients who have chronic illnesses. And if they keep getting quality care, and they get their patients better, then they're going to get the reimbursements more and more. I think that's one huge way. And that's taking away a little bit of the power from the insurance companies dictating, oh, you can only do this test, or it's going to deny this procedure, deny this medication. I think that's the first place to start.
Yeah, no, I agree with you. The whole insurance, the fee-for-service model is really interesting because it even indirectly biases you to have to do more. And that's not, more doesn't necessarily equal better, even though in Western medicine in the United States, we think more is always better. It is an interesting point that you bring up. I actually had this happen to me yesterday, and I was running just crazy behind in clinic, and I walked into the room with a patient, and it seemed like a straightforward case, like in the chart review. And I walk in, and this patient she's been through the ringer, was referred to me by somebody who essentially just wanted to kind of look at the holistic approach and talk about exercise prescription and whatnot. I had forgotten that I got a heads up on this for a long time ago. So I didn't have that in the back of my mind. But I walk in, and the first thing patient says to me, "You're my last hope." And I was like, oh boy. And she had told me how has had EMGs, and the symptoms were so incredibly vague, just like heaviness and weakness of the leg. I was like, okay, no pain, right? And so it's like, okay, not a lot of people come to the clinic when they don't have pain, they don't have weakness, they don't have like a true pathology or dysfunction that's going on, but just subjectively describing these things, but didn't want anything, didn't want medications, didn't want to do any further diagnostic stuff, wanted, essentially at the end of the day, what I walked away after that and I reflected back on is wanted reassurance and just wanted the blessing to, hey, let's continue exercising, let's try to stay as mobile as possible. But I had to get there by actually just taking motivational interviewing one-on-one, which I didn't have the time for, and I was already pressed for time, I was already behind, and this is something interesting Josh has been asking me about that we should talk about, what it's like to transition into attendinghood. The pressure is just night and day. It's different, right? But you're just not prepared for that. Like I was never prepared for that. And I think I get pretty good quality training. I've had some of the same mentors, Jerry Malenga, that I know that you've spoken about. And people like that have prepared you to have this conversation. But until you're the guy or the girl doing that thing, and the pressure's on you, the patients are on you, your schedule, your billing, your time, it's just a different animal. But at the same time, I think about it is how do we get the students ready for it? Because students work with me now, residents work with me now. Do you have trainees rotate with you?
I'm open to it.
Yeah.
A few medical students have stopped by and rotated for a day or two.
Yeah.
I have the benefit is I can kind of keep it honest with them when they're in there and tell them like, listen, like
Right.
a lot of this is a lot of work, and I haven't told any residents this, but I have some fellows that graduated after me from my program. It's like, listen, that first time you have that needle in your hand and no one else is coming to save you, even though like it's all on you at that point. And if something doesn't look right, it's not going to look right. So it is a steep learning curve at that point.
Yeah, Nikhil, I think one of the issues, as we're going to talk about, right, is kind of pre-meds have no idea what being a medical student is, and then that transition to residency and then attendinghood, right? Kind of what Altamas just talked about. And that becomes a question in terms of, well, then what is the scope of the provider? I thought I was going to do XYZ, but now I'm doing ABC. And, I never knew you were in the UK if like your first year of med school. Going to Caribbean school, how do you think was your education any different than doing an MD or DO school here in the States, at least like the first two? And then like second fold, having that experience in the UK, did that teach you anything in terms of maybe different healthcare systems?
So the first question is, let's see how I want to word this. So the first 2 years, I mean, in my opinion, are the same. It's the same books. We read the same textbooks. It's just different people teaching you. So, I don't know. I'm so anal retentive. I want to get all A's and B's on all my tests at all times. So like I was still studying all the time. I kind of isolated myself, and I think I needed that isolation from my friends, my family, weddings, and all that stuff in America. And yeah, it was a little miserable, but it was what I needed to do for that time. I don't think we definitely didn't have the close access to hospitals in our medical school, rotating, see the cool surgeries, go to these grand lectures. We had a little bit, but it wasn't like the same, and we know it wasn't the same. And then secondarily, we were learning from a lot of European trained physicians, UK trained physicians, which is fine, but their hospital systems work so differently. So, that was the first time that we call it A&E accident, ED here, and accidents and incidents or something there. I forget exactly what it is, but that was the first time we hear that term. I was like, what is that when we have a clinical vignette? But the physical exams, they're the same. Heart murmurs sound the same.
Right.
So, we take that stigma away. And then, we come to the U.S. and, I didn't notice any difference between the med students that we went to the med students that went to U.S. schools, at least in New York. Now, across the nation, I'm sure there's going to be outliers on both ends of the curve.
Sure. And then that second part, in terms of the UK, what was that experience like? Was there anything that you were just being about the UK, you thought the healthcare system might be differently, or in your mind you said, oh, wow, I can now look back and see either the advantages or disadvantages between the two nations?
There wasn't anything specific because we didn't do very many rotations or clinicals there. It was, we practiced clinical stuff, clinical exams on each other, but we didn't go to any clinics or hospital systems. So just based off of what they were teaching us.
Gotcha.
I want to jump back to kind of what we were talking about a second ago. Like, you were very passionate about making sure that we address the business of medicine, right? At the outset, you started with that. And also a lot of these philosophical topics, things just don't get taught in those first 2 years in textbooks. And in third years, you really have these, we call them COMATs, you're an MD. So I forget what your shelf exams, right? And then you're worried about step 3, and then, then you're worried about matching. And then, so we're so tunnel visioned, as Darsh has alluded to before as well, do you think, like, we can have this conversation now, I put this in quotes just because we're enlightened, but if you rewind the clock and if we go back, it's like, were we ready for this conversation, right? So I'm thinking about, it's like, how do we educate the current medical students or residents and stuff like that? It's like, when we're so hyper-focused and you're just worried about that next carrot match, like the sports match was last week, and I was just thinking about that residency match is like, if I have these conversations, like, I don't want to hear that, right? It's like, how do we do that? How do we put that into the curriculum? If you were czar of a medical school or just the medical ACGME system, it's like, how would you instill that? Where would that be? Is that even the appropriate time for medical students or residents or fellows? Like, what's the level, you know?
Yeah, I think you would want to do it towards the end of MS4 year when there's more time.
Mm.
There should be more real talks about these kind of things. And that's what my whole YouTube channel is about, is just having a real talk and sitting down and having conversations, that things I wish I would have learned. Um, I think another time to look at it is that last year of residency, where you have more time. Um, and I think it's hard to find mentors that are going to be straight shooting and talk about those things, because if you're at a university hospital, they can't talk about it. Even if they can talk about it, they might not even know it. So um, I think those are two valuable times. But I think, to your point, you might need to just get in there and feel it for yourself. I can make 10,000 videos and have 50 million hours viewed, but until you actually do it, you're not going to really feel that.
I totally agree. I mean, you can tell any 18, 19, 20-year-old pre-med student about not going into medicine because of this, but there's just something about being at that age and saying, you know what, no, I'm going to do it because this is what I want and this is my perception of it, right? I mean, I was in a 7-year BSM or BS, yeah, MD program. Thank God I didn't make it through, because honestly, having those gap years is kind of what led me to just being more mature in terms of my thinking and going into medical
Yeah.
school. I do want to transition into social media. So you started a YouTube channel. You're active on social media, and one of the back and forths we were having was on the Paul Saladino video talking about root cause, right? And this term root cause being thrown around everywhere. What is your thought on that? Because Paul Saladino says we're not taught that in medical school. Obviously, he had a professor rebuttal saying, well, we learned the root cause of TB. How do you break down the word root cause when so many people, patients as well as providers, are looking at that as not only a marketing term, but also people believe that we truly need to reform the education system to talk more about root cause?
Yeah, I think that's the question, right? Like, I would challenge any of these people that say, I'm treating the root cause. Okay, what's the root cause? Spinal stenosis. The spinal stenosis is because, you have bad posture and this and that. It's like, well, actually, because an enzyme isn't actually working in your body to eat up the collagenase to make your ligaments. So how are you going to go back and treat that? Do you know how to go and treat that one single enzyme? So it's so easy to say this, but when we break down root causes, like, we're talking like micro DNA, RNA changes that cause cascades of events. We can talk about any root cause, like when we talk about inflammation. That's increased ILs and leukocytes and proteinkine's and all those things in your body floating around. It's not just a one small thing like, oh, you got to fix your eating, the root cause. Like, what is the root cause? That's the way I see it.
Yeah, no, I agree. I think when we look at root cause and even look at like the functional medicine certifications, right, they go so much into the biochemical pathway, which is cool, right? Because it can at least tell you the evolution maybe of a disease. It's kind of what we learned in medical school, but maybe we just haven't learned in that much depth. The way I see root cause, and I wrote this in those comments too, is it's kind of one is your approach, right? Is like the treatment root cause, which we do learn in medical school. You learn that, hey, cigarette smoking can cause this, and if you have this disease, you can trace back. But then I think people confuse root cause with preventative medicine, which I think is what we should probably be using
Yeah.
more of, and focusing on goals and
Yeah.
themes, at least, right? If we're talking about nutrition and exercise, how do we set up things so that we can prevent those diseases? Let's start at a root, right? Now more than ever, let's not go backwards, but let's think forwards. And so I think that's the way I think about it. Altamash, I don't know if you have a different definition or kind of what pops into your mind.
Yeah, no, what does pop in my mind, and I think again, I think about one or two challenging patients I had recently, where they came in and they said, "This is what's going on, and I need to know what's going on." And again, they've had all the tests and stuff like that, but then I had to ask them. I sat down and I was like, "Well, what's more important? Is it more important to know, like to find out what the cause is of your symptoms that you're experiencing, or is it more important to get your life back. What you're telling me that you can't do and you want to do. Like this person wanted to run a marathon and was like, I was running half marathons and like, and now I couldn't. I was dragging my feet, and people 10, 20 years younger than me were able to do this. And so I asked that person, and the person paused and said, yeah, I guess the latter's more important, to get my life back. And I was like, what would it look like if we never found out what the cause is, but we were able to get your life back? Would that be acceptable? The person was like, yeah, I guess that would be acceptable. So I was like, so then maybe let's focus on the latter, right? I mean, of course, look, we got to rule out the red flags. We got to make sure everything's safe. But to me, sometimes it's just not practical. Sometimes it doesn't even matter, because I mean, we talk about this for diagnostic tests all the time, right? It's like, if it's not going to change your management, why are we ordering something? And so, these biochemical pathways, I love doing this. I mean, Darsh, we like to nerd out. We talk about it offline so much. We're texting back and forth all the time. It gets really interesting. We listen to a lot of the same thing. And Nikhil, you do as well. I mean, we're all sharing the same stuff. But when it comes to actually like seeing the person in front of you, a lot of the basics carry, they go really far. And so sometimes it doesn't even really matter. And so I'm less interested in identifying the root cause and more interested in just helping people and whatever tools or however we get there. I don't know if that answers your question or not, but
Yeah, I think so. I think all three of us here are looking more towards progress rather than going back and focusing on having your cake, and having two, right? Having a slice of cake, having two. So no, I agree. Nikhil, if you have any more comments.
I got a good question for you guys when you get a chance. Yeah, no, yeah, I do, because I feel like.
Wait, you don't get that question. I'm kidding.
Awesome.
Sorry, go ahead.
No, yeah. So I think it's awesome because we all kind of do have the same, and we have all three at different approaches, which is, I think, even better, right? I've said multiple times to patients come to my office, all test and all this, and everything's negative, and it was like, listen, you're the exact person who shouldn't be seeing a doctor, because you're gonna get all these thoughts in your head. They're gonna tell you this, tell you that, yada yada yada. So we all have our different ways of saying it, and that's how I say it. You have a different way, Darsh has a different way. So my question for you guys is, do you feel like PM&R doctors are gravitated to that kind of receptiveness in how we view medicine, or is it taught to us? So born with it, or do we learn it?
Oh, wow, that's a good chicken or egg question. Oh, yeah. I think it's tough. It's a lot of bias. Of course, I gravitated towards that, but I do think in residency it was emphasized a little bit more, which is why. So I knew about PM&R my first year, which is very early for, I think, now it's more popular, and I only knew about it because in the sense that I wanted to practice non-surgical musculoskeletal medicine. Right, and really sports medicine, because I went to medical school. I was like, I'm doing sports, and I only knew that you could go into sports through ortho or family or something like that. I didn't know about PM&R. Once I learned PM&R, I was like, oh, I'm doing non-surgical MSK. That's what I'm doing. It wasn't until I shadowed Jerry Malenga, Nikhil, where when I took this stuff, I was like, oh my God, right? We were talking about quantum mechanics, and I was like, what does that have to do with anything? But it has to do with everything. And again, so I'm an osteopath, right? And so we were taught the quote unquote holistic way, but Dr. Malenga is not. And he's talking about OMM, he's talking about this, he's talking about curcumin. We're podcasting about this now, like 10 years later. And I was like, okay, this is the guy, like the way that he thinks about a problem. And then I did my residency, my away rotations, and I found a lot more people like that. And so, I think it's hard to disentangle whether it attracts or if that's taught, but maybe it does attract, and those people are now teaching, and they just continue to pay it forward. So I don't know.
Yeah, I don't know. I guess it's tough. I mean, when I look at it, I think a newer generation of physicians, the ones in med school right now, I think we tend to be more holistic. I think we're more data hungry, right? I think the advent of social media has caused that. It's caused us to have debates and actually talk about seeking the truth, right? Something that I think all three of us really do talk about is, Nikhil, you put a great video out lately on your YouTube, right? Like things that you thought were true, but aren't. And I've been, and that's inspired me to kind of make a list of like the last 5 years. What are those things that I'm looking back at? And I think that's the beauty of kind of our generation, right? Is that we're really trying to look at it in terms of coaching, but also trying to receive as much information from patients. And so motivational interviewing, but I almost find it really impossible to do given a 30-minute limit. And it sucks to see how insurance dictates the way we even ask questions, right? Not even what we kind of order, but just even the way we ask things, just so we can be more time sensitive. And so I've kind of adopted this philosophy, at least when med students are with me, is that I'll try to like ask and influence at the same time. And I found that patients enjoy that. And I just try to teach. I try to teach patients things that they may not have known, but will make sense, and try to just break it down. Like, hey, exercise, this is what it does. No one's probably taught you this, in terms of like your heart rate, and like just like one or two facts that they're like, oh, whoa, I never knew that. I was always taught something different. That's been my approach lately, at least like in the clinic. And I think it also depends on the patient population, right? Like I plan on going fee for service probably, just given like what I want to do and kind of how I want to work with things. And that's going to attract a whole different, patient population for sure, compared to what both of you guys are seeing right now.
Now, I know Darsh wants to get your take on approach, and as do I. But before we do that, we talked a little bit about social media again, and we're all somewhat active on that. Twitter is so YouTube and Twitter, that's where you primarily spend most of your time.
I mean, yeah, I'm on Instagram, I'm on LinkedIn. I get pretty active on LinkedIn too, more of, business side of things. So each platform has its own
a little bit different.
Yeah.
So as I mentioned, I think a lot of people now are getting, sometimes their primary source of information is social media, one of these platforms. And we're pretty active too. And one of the things that we try to do is put out good information. You do the same. And so, the good comes with the bad. And sometimes there's a lot of bad. So I want to ask you is how do you, when you talk to people, if you're making a recommendation about following somebody, is how do you suggest people can filter, through the noise, all the noise? There's so much noise when we're talking about this root cause, or, those people talking about root cause, it's dairy. No, it's gluten. It's this, to get the signal of like what health means and stuff. What's your thought on that?
Yeah, so it's funny you asked that because I'm battling with that myself, and it's actually going to be my next YouTube series or next video kind of talking about, really comes down to this, and this is it. What is the primary motivator of that individual? So if we start with that, and it's like, oh, I really want to help people. Okay, that's fine. If you really want to help people, then go help people. Don't go on videos saying that I want to sell all these things, and because like I don't want to use anyone's names, but because I'm trying to get away from that. But like there are these influencers out there that say all these things, but then you go look in their backlogs, look at their tax records. They're getting flown out to these conferences. They're staying at these hotels. They have their supplement lines. They're all over. And now it's became a joke. You don't want to help people. You just want to make yourself money. I mean, let's call it what it's called. Like, there's nothing wrong with that too. If you want to make money, go make money. But don't say you're trying to help people and educate the world when you're just using your own data points. And I think that's usually my biggest filter is like, what is your real MO here?
Let me push back on that a little bit.
Yeah.
And I have no idea who you're talking about, but I mean, can somebody do both? Can somebody like make money and also have the incentive? I mean, because at the same time, this is a business, right? We talk about the business. You have a private practice, so you are intimately involved in every single business decision you make. We don't make money. You don't get to help people. You know what I mean? So Can somebody want to do both?
Absolutely. How willing are they to change their mind? Like I said in my YouTube video last week, a couple weeks ago, there are things that I thought 100%, there's no way that this is not true last year. And here I am this year, I'm like, well, damn, I was an idiot. I was thinking just today, man, I need to go to more courses. I need to go learn more. I've done thousands of cases. I've done, tens of thousands of cases throughout my training too. It's like, no, I need to go learn more. So these people that pigeonhole themselves into only studies that fit their narrative doesn't make sense.
Yeah. Nikhil, I want to delve into your approach with patients now, right? Because I think, earlier you just talked about, you do talk about kind of the pillars of lifestyle medicine or just, health in general. But let's first start off, like who is your typical patient coming in?
I have a good referral sources from physical therapists that know that, I'm going to sit down and talk to the patients and, they've gone through physical therapy. Some chiropractors that similarly have war talker to the patients like, hey, just not getting there. But most patients that end up coming are between 50, 60, 70 years old, have chronic back pain or new onset of back pain, exacerbated, whatever. So that typically is who's coming through my door. My target audience is any musculoskeletal injury, as I think all of us kind of want to focus our strengths on.
Sure. So, okay. So 50 to 70-year-olds, different generation from us, obviously. What are their expectations when they're coming to see you? Is it mainly just pain relief, or is there maybe something extra that they ask for?
I think that comes into when you're sitting down and talking to them. First off, I don't do opioid management out of my clinic. So my MA, my scheduler, they know as soon as they pick up the phone, okay, you want to get a point? Are you on opioids? Do you want to remain on opioids? Because we're not going to take on those cases. So at least we filter that out. They still come through, and that conversation starts really quickly. The conversation starts the same way every time, and I think, and when you've experienced it, but you go along with it. And it's the motivational interview, like, okay, what are your goals? What do you want to do? And that, I think that's the point is, what would you do if you're out of pain? So, I have this one patient, all they want to do is they want to go back working. Like, great, that's a fantastic goal. How can we get you there? And that's typically what I'm saying is, like, if the first thing doesn't work, we got another thing. If that doesn't work, we got another thing. We'll get you there.
Yeah, I love that, right? That's a true PM&R motivational interviewing, ask about goals, and that's like the one thing that I've been taking to the neuro clinic or sports medicine or, is asking the patient, what do you want out of, like, what are your goals? What can we do for you? And what are you hoping? And that can honestly save 10, 15 minutes out of a visit and direct better care. So I definitely agree with that and love that. So again, 50 to 70 years old, do you feel like they might be out of touch in regards to the way you practice healthcare, right? Because they might be used to a different system, how it was when they were looking at doctors with paper charts. How do you navigate that?
Yeah, so I think a lot of them are used to, just give me a pill and let me see how it goes. And so, I have my handful of NSAIDs I prescribe, muscle relaxers that I prescribe. Don't love giving gabapentin all the time, but that's another one I'll give. Some chronic pain stuff, SNRIs. The families of medication, so it's just like, this might be the best thing. And sometimes that's all they really do need. And perfect, that's fine. Go. But no matter what, 100% of my patients are going back to physical therapy or chiropractic. So, and the right chiropractic, in my opinion, you need to know what they're doing and stuff. But yeah, so that's kind of how I function out of my practice. I'm going to give you something that make you mentally feel better, in the goal that you're going to go do the work to make yourself feel better.
Okay. So when you talk about the work, right, how do you approach that topic? Because the work can mean different things to different people, right? It could be getting more sleep so that their pain goes down by a little bit. It can mean, hey, you actually got to go through physical therapy and actually show up to your appointments so that pain can go down. How do you influence in that regard?
So yeah, that's a very sensitive topic because I think it's personal for everybody. If it's like, I went to physical therapy before and it made me worse. I'm like, okay, show me what they taught you. What'd you do? Mm. And then, I don't know if this was like, that's trash physical therapy. You went to some cookie cutter place that didn't work on you one-on-one. And this is how I talk in clinic. I'm like, that was a waste of your time. Like, then I literally will get on the floor and show them stretches and movements. Like, no one's ever taught me that. It's like, all right, well, let's try this for a month. Yeah. I think that's the way I could just motivate them. It's like, I'm literally showing I got bands in my office. I got, clean my floors all the time. Yeah. So, and I clean my own floors, so I know that I'm doing it right. And that's what I do. And I think a lot of people see that, and that I'm actually listening to them on the other end when they're telling me their problems. I think those are the two biggest portions.
I love this conversation you guys are having about active participation. The patient is the active participant in their own care. Often I'm telling my patients, I'm like, listen, this is your show. Like, I'm just along for the ride, and it's not, again, to Darsh's point, like that mentality of they go to the doctor's office, that paternalistic relationship. Doctor tells me what to do. Doctor's right. I'm so excited when patients come in and they've already watched YouTube videos on the procedures that I'm gonna do. I have had a patient ask me to do a different approach, and I'm like, okay, that's where we draw the line. But but I love it because I'm like, listen, you got to do the work. Like I can't, I do a lot of OMT as well, and then we have these patients. We're talking to students about this today. Is they come, they get treated, and they're like, okay, can I come back next week? And I'm like, no. We have to, once we quote unquote fix the alignment, you have to do the exercises after that we've talked about to make these changes stick, right? And I tell them, listen, I'm going to prescribe physical therapy. I'll write 1 or 2 times a week. Physical therapist makes their assessment. They might make a suggestion, but with a home exercise program, like you're not going to do that work or whatever changes you're making, and they're not going to stick from a 45-minute session twice a week max. Like that's not going to happen. And we're just used to, in this culture, is like our idea of recovery is going to get a massage. Again, it's all passive, right? Darsh's he does the ready state, right? The virtual mobility coach, just like active recovery. You have to do your foam rolling, you have to do your stretches, you have to make sure you're doing your squats or whatever it might be. And I don't know if we're unique as a country where we're more into that, where like we don't believe, we're more into passive modalities, massage gun, heat, ice, stim, that kind of stuff. But that's such a critical point, I think, when we're talking about chronic musculoskeletal medicine, because I think that's what we're essentially talking about here, right? Like the acute stuff, that's different. Fracture care is different. Bone sticking out is a little bit different. Wounds are different. We're talking about chronic musculoskeletal medicine, which is what 90% of what we see.
I'm dealing with the shoulder thing right now, and I schedule my physical therapy, and I'm like literally like, okay, I can do one stand on my left arm straight out, I'm good. Go on my right and start shaking, and they can see it. It's like, this is why I'm going to physical therapy, because I know if I don't treat this now, that's going to be torn rotator cuff, that's going to be a surgery. So why don't I fix it now? Anything you put off is going to bite you in the butt in the long run.
Yeah, there's a really good quote I heard from Eric Cressy, who I think he's not there. I forget who he cites. He talks about, I think it goes something like, pay attention when it whispers before you have to listen when it yells, or something like that. You know what I mean? So that's kind of when you talk about, it's like when people have this little nagging injury and they ignore, and then it's just complete shutdown. Now they move their arm. So I think that's really, really critical. I think people that do that earlier on, and not just push through the pain and stuff, will be in better shape.
Or mask it with like non-steroidals. Sometimes it's like, that's actually probably more detrimental for your chronic musculoskeletal health. So, my friends always ask, oh, you don't have ibuprofen in your house? I'm like, no, because if I'm in that much pain, then I need to go do something about it.
Yeah, I think it goes back to the culture too, Ultimash, like you were saying. I mean, we in the US believe in this no pain, no gain mentality, right? And like for those of you guys who know E.T., the hip hop preacher, right? He has that like amazing motivational speech about not sleeping, and sleep is for the weak. And so it's funny that we buy into this culture of like hustle, right? A hustle culture that leads to passive income and wealth and essentially retiring early and being lazy. And I don't know how much of that actually translates, like you're saying, into kind of, we've experienced pain, so we've done the work already. So now we should be rewarded for a complete solution, which could be heat or ice or whatever might be a little too passive. So I don't know.
That's funny, Darsha. It reminds me of that story, the fisherman who's like, fisherman in Spain, you buy the fish right off the boat, and this wealthy American businessman is like, oh, how much money do you make? Oh, I make enough. Oh, what do you spend how many hours you work? Oh, just 3-4 hours a day. What do you spend the rest of the time doing? I sit at home, cook with my wife, play with the dog, take a nap. Oh, well, you should be working all the time. Go out and buy all the boats and get all the fish. You can make millions of dollars. And then you can retire. And the fisherman's like, and then what do I do? Well, then you could be at home with your wife and nap and play with your dog. So it's like, when you start putting things in perspective like this, it matters.
Yeah.
It's just, oh my God, this hits home right now, because I just picked up this book, Bill Perkins, Die with Zero. Great concept, and he talks about this. I know you guys might have heard him on some of the podcasts.
Yeah,
it's exactly what he talks about. It's like, most of the people, they save, and they give up thousands of hours of their lives, and there are different seasons of your life where you can enjoy the stuff. So we're talking about, when you're 70, you can play with your dog and that kind of stuff. But when you're 70, you might never get to go skiing or snowboarding or wakeboarding that he talks about and stuff. And so why not do that when you're 30, 40, and 50 and just work a little bit less? It's something that I've been thinking a lot about now. And I get the sense you are too, into financial education. We've had a couple of podcasts about that as well. student loans and stuff. And I was big into, when I first started, I was like, oh yeah, fire. I'm all about the fire movement. I was like, yeah, 45, I got to get rid of my disability insurance. That's my goal and stuff. And I've been reevaluating that whole thought process for the last month and a half now. And I'm excited to read this book. So, maybe after I'm done, we can talk some more. But dude, you talked a little bit about your practice, kind of your approach. Thank you for sharing that. Tell us, what's next for you. What are you excited about? I know you got the YouTube stuff going on. You're active on different social platforms. What are things that get you excited, and what are you looking forward to?
Yeah, I think I'm still in the growing phase of my practice, or as I feel, so trying to make that most efficient as possible. In talks with some people around the community and partnering, either loosely or directly, however that might work out. Just always looking for an opportunity to help more patients, find people that are like-minded and have a common goal. I have a goal that there's this Oklahoma surgical center of Oklahoma, which is like all cash-based, everything. So you know exactly what you're paying. You can go payment plans, all that stuff, and it tends to be a lot cheaper than the facility fees of hospitals and other surgery centers. So trying to find a group of people in the Central Ohio area that are motivated by that, and getting some chronic pain lectures out to the public. So that's where I'm at. I'm excited to see where AI goes. I don't know how it's going to fit in for us yet. I know it's going to be advantageous. I just don't know how quite yet for us. And really just trying to spend some more time with family. To your point, also, one of the reasons I moved back to Ohio is to be closer to my parents who are here. It's like, it's been talked about in different realms, but it's like, you look at a scale of your life, it's like, okay, how many more summers do I actually have with my parents? So it's real important for me to be here with them, and we're enjoying so much time together. So it's been a big blessing for that.
Yeah.
I love that.
For sure. We'll definitely link the Wait But Why article. I think it's by Tim Urban, who talks about the how much times you have with your parents and stuff. It's a great read. Nikhil, where can our listeners find you? What are your socials?
Yeah, I'm on Twitter, LinkedIn, Facebook, Nikhil Verma, MD. There's also a Nikhil Verma, MD in Chicago, Illinois, so don't get us confused. My YouTube channel is called Things I Didn't Learn in Med School. Not popular enough to come up just based on looks itself. And then I'm just confirming my updated. I try to uniform my name across all the platforms, and I think it's Dr. DRNV Sports Spine. I'm just double checking that right now.
And I can also find. I'll put in the show notes so that for listeners out there, easy click away.
And honestly, anyone reach out if you have questions, if you will comment, if you have topics you want me to explore. I'm happy. I love doing this stuff. I love researching for these kind of things. So
Nikhil, I want to put you on the spot here real quick before we ask your last question. If you could go back to being pre-med, medical school, residency, what are 3 things that you would tell yourself to learn that you didn't in medical school?
I think one would be how to communicate with patients, and how you could communicate with even hospital staff. I see how poorly even doctors, all the way to medical students, do that, and it breaks my heart. You should be nice to everyone at all the time, even if they're not nice to you.
Is there a resource for that you recommend people do? Like, how do you recommend people learn that?
Okay. I don't know. And I was honestly thinking about starting a course just for that. And maybe we can put our heads together and record different ways to do that. That would be awesome. I think that would be a must-be-seen thing. I think it's worth your time to understand every step involved, getting that patient in the door, and how does a patient get scheduled in the door? How do they get their medications, and every step involved? Because it's not just, doctor writes the script and it's done. There are 14, 15 layers that you're not even looking at. And I think that's important for people to know. I'm not saying you have to memorize it, just like, oh, wow, that's why everyone's role has a spot. And to understand how insurance model works, because right now it's not working, and these fee schedules and all that stuff is pretty insane. Even with these No Surprises Act, that didn't really stop people doing from what they want to do anyway. So I think it's worth the time to go read and look into that as well.
Perfect. Yeah. No, I think you have some videos already on some of those topics, so we'll definitely put your YouTube on there as well.
Well, man, thank you so much for jumping on here for an awesome conversation. I'm excited to do more of these in the future, and I agree with you. I mean, those are all must knows essentially. That's even a thing, but things for people to consider and learn more about. And like I said, I'm excited. I think the next generation of physician has more opportunity to do this. Even people tuning in, well, at least if it piques their interest, then they might go Google and read about it. And everything's accessible now, so that's what's cool. Yeah. But man, last question that I cannot give you a heads up on in the beginning is it's very, very important for us to kind of think about all the time is, we talk about practicing a sick care system, right? Not a healthcare system. So the question becomes is how do we add the health of healthcare, and can we even?
Yeah, I think it starts and ends with the education that we can provide our patients and friends, family, talk about what's right and talk about what we talk about mainly in clinic. It's never the one patient that comes back to you that's like, oh, this didn't work for me. It's the one that comes back to you and says, you changed my life. I'm going to trust you with everything. And that's what I had a really crummy day today, but I thought about like those patients just for a brief second, and this is why I do it. This is why I put up with the crummy days, because the back end makes it worth it. So I think that if you keep that mindset, we can go so much further collectively.
Like that. Well, thanks, man.
Awesome. Thanks, Nikhil.
Appreciate you guys. Have a good one. Hope to do it again soon.
Thank you so much for tuning into that episode. Before I ask you for two big favors, I do want to let you know that on our next episode, we will be starting to publish this podcast on Tuesdays. Previously, we were publishing every Monday, but this time it will start on Tuesdays. So don't be surprised when you wake up in the morning on that Monday and you don't see us. We'll be there the next day. Now, of course, back to the favors. The first one, if you enjoyed this podcast or you think you know any pre-medical or medical student that would benefit from this, please send it their way. I believe it is our duty to really prepare the next generation of physicians so that they don't get caught by surprise when they're in our positions and they're about to become attendings and have to start understanding the business of medicine and really looking back at why they didn't learn the things that they should have in medical school. Now, the second favor, on your preferred platform, please take the time to rate and review this podcast. It really helps us to broadcast all of our episodes to listeners just like yourself. Special thanks to our team, Iman Bashiri, Harita Yepuri, and Ethan Ju. And as always, the medical disclaimer, everything in this podcast is for educational purposes only. It does not constitute the practice of medicine, and we are not providing medical advice. No physician-patient relationship is formed, and anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your personal physician regarding any specific health-related issues. And we'll see you next Tuesday.